Welcome everyone to another Life and Breath Foundation educational webinar. My name is Saul Kachauskas. I'm a board member here at Life and Breath Foundation. We're very happy that you've joined us here tonight. Tonight's topic is tests to get after the sarcoidosis diagnosis. Before we start, I have a few words about the Life and Breath Foundation. Our primary goals are to offer the sarcoidosis community effective tools to track their journey, decipher medical issues, and maximize their quality of life, to provide a nurturing environment to those affected with sarcoidosis so they can share their experiences, to build more awareness within the medical community, and to help combat this chronic disease. During tonight's talk, please remember to use the question and answer function when it's time for questions. We'll do our best to get as many answered as possible. Okay, our speaker tonight is Dr. Elisabeth Carr. Dr. Carr is a program director for the internal medicine residency, as well as a practicing pulmonary and critical care physician at the Greater Baltimore Medical Center. She has substantial clinical as well as leadership experience in graduate medical education. She is a graduate of New York Medical College and was elected to the Honor Society Aloha Omega Alpha. She completed her residency and fellowship training at Thomas Jefferson University Hospital in Philadelphia. She stayed on as faculty in the Division of Pulmonary and Critical Care Medicine, where she developed an interest in the impact of autoimmune disease on the lungs. She developed further interest in sarcoidosis and has been working with sarcoidosis patients since 2001. At Jefferson, she was an assistant director, program director before moving to Salt Lake City, where she joined the faculty of University of Utah. She was core faculty for the medical school. Later, she moved to Baltimore in 2015, where she joined GBMC in pulmonary medicine and an intensive care unit. She joined the internal medicine residency as associate program director in January of 2020 and became program director July 1st, 2020. She is thrilled to work with her team and the chairman, Dr. Melvin Blanchard, to create a best-in-class internal medicine residency with a strong national reputation in patient safety and quality. Welcome, Dr. Carr. The stage is yours.
Thank you, Saul, and I'm really glad to be here. Let me see if I can figure out how to share my screen smoothly so that I can start with just sort of a little slide presentation before we get to the question and answer session. The last time I joined you guys, we had a very brief slide presentation and lots of questions. So I've tried to keep this brief again. And really what I wanted to talk about this time around was, once the diagnosis of sarcoidosis has been made, what do you need to do next? What kind of testing do you need? And what does that look like for you? So before we really jump into the talk, I just want to remind everybody sort of what sarcoidosis is. And I know a lot of people know that already, but I just kind of like to go over this. So it's immune dysregulation. And what exactly does that mean? I know anytime I say that, it's a total panic. Oh my gosh, what does that mean? So really the way that I like to think about it, for those of you that were there on the webinar last time, you might remember this, but for those of you who've never heard it before, sometimes I find it really helpful to think about your body as your country. And if you think about our own country, we have military that protects our body, our country, and the same thing for our body. So we have 5 branches of the military that protect our body against the outside world. And in sarcoid, you have one of those branches of the military that gets overactive, and it creates these granulomas. And it's sort of like trying to create these walled off areas. And similar to how an oyster makes a pearl, where you get a grain of sand that gets inside the shell and it irritates the oyster. So the oyster spins a cocoon around the grain of sand. As you can see, these are little pearls that are actually made inside an oyster shell. And so the body tries to do something similar, where these granulomas are technically walling off something. We just don't know what that grain of sand is for the human. And so this is what it sort of looks like under a microscope. And the dark purple and the pink scattered stuff that you see on the outside is not totally abnormal, but this, let me see if I can get my laser pointer to work. This center circle of light pink with these round, darker pink cells are really actually the granuloma. And so it really does give that impression of something being walled off. And so that's kind of the way I like to think about sarcoid. And the one thing that we know is that granulomas can get into any organ in the body. And the most common ones that we see it in is actually the lungs, with over 90% of patients having lung involvement, and also the eyes and the skin. And so that gives us the impression or sense in the medical world that this is something that might be environmental, something that you might have inhaled or been exposed to through the environment like that. So as you know, there's just lots of things we don't really know about sarcoid. And so we're still in the process of trying to figure it all out. So because it can get into every organ, when we find somebody who's been diagnosed with sarcoid, we want to look for it in places that it might hide. And so we want to assess each organ. And how do we do that? Well, we start by asking questions of each area. So I think of it as head to toe. It might be questions like, do you have a headache? Or do you have problems seeing? Or do you have shortness of breath going down to the lungs, etc.? And then the other thing that we do is a physical exam from head to toe. And on that one, we're looking for skin rashes that might actually help discern whether or not this looks like sarcoid. And we would certainly be listening to your lungs and your heart and seeing if you have any abnormal sounds there that might suggest sarcoid, or if you have liver involvement. So you might have either a tender liver, or you might have a large liver. So these are the things that we do that will help get a lot more information for us. And then we do testing. And so the testing piece is really where it all starts after you've had that diagnosis made. And so the first thing is going to be a CAT scan of the chest. And for most people who come with a diagnosis of sarcoid, I would say they already have had a CAT scan of the chest, but you never know. So you're going to get a CAT scan of the chest. And then the next thing we're going to get, oh, sorry, my thing stopped working. We're going to get blood and urine tests. And on that blood and urine, the blood tests, we're looking for things like anemia with a drop in your hemoglobin, which is part of your bone marrow potentially. So we look for bone marrow involvement because that's another organ it can get into. And so bone marrow involvement might also show up as low white blood cell count, if you've ever heard of that. We look for liver function tests because that will help us understand whether or not your liver is involved, kidneys. And so we look at creatinine for that, and we look at calcium in the blood because that's actually one of the things sarcoid does, is produce this calcium. And then there used to be a test called an ACE level, and if you've ever heard of that, and we used to actually use it a lot in sarcoid. We would use it not only to help us with the diagnosis, but we would potentially even follow the levels to see if there was any improvement. And it turns out actually that we found out over time that it can be high when you don't have sarcoid, and it can be normal when you do have sarcoid. So it turns out it's just not very helpful for us. So we don't really use that anymore, even though some of your doctors might still order it. It's not wrong that they do it, but it can't really be the end all be all. And then we'll look at your urine to see actually about calcium. And most of the times we'll do a 24-hour urine for calcium as opposed to just a spot calcium check. But that's just one of the other things that we do. Okay, then you should have a screening EKG. And when I say screening, I mean you have no symptoms of any heart disease, meaning you don't have chest pain, you don't have things that might suggest that your heart's in trouble to begin with. So we do an EKG, and that actually can really help us identify whether there's some granulomas in there. It is not the end all be all for us, but it is a good starting place. Now, if you have symptoms that are suggestive of the heart, then we're actually going to start getting more narrowed and more sophisticated. And so here we're going to get either a cardiac MRI or a cardiac PET scan. Now, if you live in a rural community far away from access to advanced care, you're not going to probably be able to get a cardiac PET scan. And even a cardiac MRI might be tricky, because it's not that the MRI is special it's not different than any of the other MRIs that they might do of the body. It's actually who interprets it and whether or not they're able to look for the things in particular that we want to look for. So sometimes that can be hard. Do you need to travel, 500 miles to go get this done? If you have heart involvement, yes. If you do not, no. You're going to want to see an eye doctor. And we really, actually, this is a big emphasis, because sarcoid can get into the eye and have absolutely no symptoms until it's too late. So there is a sarcoid that is a part of sarcoid that can get into the front of the eye, like where you might, see it just looking at it, and that can get red and irritated. It can be painful. And that is actually good in a sense, because you're going to get medical attention for that. But the problem is when it's in the back of the eye. So you need a special eye doctor for that. So usually I would recommend an ophthalmologist. They are MDs who went to medical school, but they're also surgeons that deal with the eye, as opposed to an optometrist, who's somebody who actually can do a very thorough eye exam, but maybe more about prescribing your glasses. So if you don't have access to an ophthalmologist, as long as you have a really good optometrist who dilates the pupil and looks in the back of the eye, and you tell them ahead of time that you have sarcoid, and then hopefully that should be enough. But really, ideally, you want to get to an ophthalmologist. And most ophthalmologists in the country actually would have no problems being able to identify sarcoid in the eye. And in fact, at GBMC, where I am in Baltimore, I have a couple of special ophthalmologists that I work with who I have, developed a relationship with, and I've told them that my patients who are coming, this is what we need to look for. And that works out really well. So you can certainly find people who are specialists without having to travel necessarily 500 miles for that. The next test you're going to get are breathing tests, and breathing tests really help us understand sort of the function of your lungs, whether they have any impairment that might be related to sarcoid. And also it just gives us a good baseline. So we need to have a place that a starting point so we can monitor following over the years. But you want to get that, even if you don't have lung symptoms, we want to get that early. And then probably starting about 10, 15 years ago, we really started using PET CTs as a way to look for sarcoidosis in the body. However, the problem is that insurance companies don't really want to pay for it for sarcoid particularly, so it's hard to get that study paid for and can be very expensive. Now, some patients have already been diagnosed. They came to us thinking that they had cancer, and they had a PET scan for cancer. So that is actually where we do use it much more. But when I get a cardiac PET, for example, the advantage also is that it gives me a PET scan where I can look at the whole body. PET scan, if I'm going to go back actually to the cardiac PET scan versus MRI, the difference between those two things is the PET scan looks for things that are active, whereas the MRI looks for things that are more established. That's probably the best way to say it. So getting a PET scan, a whole body PET scan for us to be able to see where sarcoid is in the body is actually very helpful. So what else do you need to do? So you've had all those tests. Well, it really is going to depend on the detailed questioning that your doctor does with you, right? So the doctor might find new or different areas that might be suggestive. For example, if you have frequent headaches, or if you have numbness and tingling on one side of your body, or some unusual neurologic complaint, then you're going to need to get a brain MRI. But there's so many different things that could happen, but the important part is getting the questioning down, head to toe questions, and then we will actually decide whether or not what tests we need to order and whether or not that test suggests sarcoid or not. So the other thing that's going to depend is the result of the testing that we just did. So the CAT scan, the breathing test, and things like that. And the blood work, for example. If we find abnormalities in the liver there, we may actually send you to a liver specialist so that you can actually be evaluated and maybe have a biopsy of your liver, We might send you to a kidney specialist if your kidney function is abnormal. And, you know, so that's sort of what the path should be. Again, I keep thinking, you know, we're lucky here in Baltimore because we have access to such great healthcare. And I know around the world, it's not always like that. So we really do hope that the doctors are able to get enough information and actually be able to start doing that workup themselves for you. So then the next question is sort of what state am I in? Like, what state is my disease in? And so we think about this in a couple of different ways. But the first thing I want to kind of just talk about is what's the phase point. So I do want to start by giving you some good news, which is most people end up living with sarcoid as opposed to dying from sarcoid. While we do unfortunately have people that do die as a result of sarcoidosis, it is really not the biggest population. So, you know, we really want to help you get through this. We want to talk about the different stages, and I'll talk about stages next, but the different phases that we have basically. So here, what we think about is we think about active disease. And then we think about remission. And so people who are in remission is where the sarcoidosis has gone to sleep. It's dormant. And it's really not in an active state. So it may still be there, right? You may still have all those granulomas, and that grain of sand might still be there. And so your body is just kind of waiting there. But since those grain of sands aren't multiplying, the sarcoidosis is not multiplying. So that's good. And then you can get relapse, and relapse is actually where you have a flare of it. So you were doing fine, and now all of a sudden you start to have symptoms again, and the sarcoid is now active again. And then the other common thing that we see is a chronic disease. And so chronic disease is more like diabetes and hypertension, where it's just always there. We work to keep it in control with medications, lifestyle modifications, and things like that. And then the last one, which is kind of interesting, is something called burnt out. And the way I think about burnt out is that the military came in, it built all these cocoons around things and took care of the problem. And now the military is gone, but we're still left with all these cocoons everywhere. So while they may actually show up on a CAT scan, they're not doing anything to impair people, and people can actually be back to normal with even some of the stuff on their CT. Okay, so now we can talk a little bit about this prognosis and staging. So it was very unfortunate. Somebody once upon a time decided that the smartest thing to do is to break sarcoid up into stages, which is very unfortunate because when I think of staging, I think of cancer. And it should not be considered the same way at all. I wish we could rephrase it or rename it to something else. Unfortunately, I do not have that power. But it's important for you to just at least understand what we mean by that. So stage 1 is actually really, and all these stages are really mostly designed around the lungs. This is how it was done originally. So stage 1 is where you have just lymph node swelling in the lungs. Stage 2 is where you have these granulomas that are in the lung tissue, and then you also have the lymph node swelling. Stage 3 is where you have just granulomas in the lungs, no lymph nodes swollen on the CT scan. And stage 4 is where you have permanent scarring. Now, stage 1, most people who have stage 1 with just those lymph nodes, we find that it tends to just go away on its own and nobody needs treatment. Stage 2 and 3 typically go into sort of these 3 patterns where we treat them and then they go into remission, or they end up having what we call remitting and relapsing, where you kind of, you go into remission and then you relapse and you have a flare and then you get treated again, you go into remission again. And that's probably what I see most commonly. And then there's the small percentage of people that have chronic disease. And then with stage 4, this permanent scarring one is actually where they can either have chronic disease or patients can have burnt out sarcoid. I do want to mention that there's a stage 0. Stage 0, this must have been an afterthought for somebody, but stage 0 is when you actually have sarcoidosis that's outside of the lung, meaning that there is no lung involvement. And remember, 90% of patients have lung involvement. So we do know that it's an important piece of it. But there are some people who actually have no lung involvement, and we just call it stage 0. We do not have great data on the trajectory of patients who have stage 0. So I can't really tell you which one these fall into, but I would say the majority of the ones that I know that have stage 0 would fall into the stage 2 or 3 pattern of remission, or they have remitting and relapsing, or even chronic disease. So do you need treatment? Well, I think that's always a huge question. And this is where I probably spend most of my time with my patients, talking to them through this, because it is not an easy yes or no. So the answer is maybe. And, most people, as I mentioned, don't ever need treatment. And we do also say that treatment really depends on location and symptoms. So I will say treatment should be symptom driven. And I think I've mentioned this in my other webinar. And I think hopefully this is a message that you get over and over again. So you really want to think about my symptoms. Are they debilitating? Are they ruining my life? Am I able to function? Am I able to do the things that I enjoy? Are they interfering with activities of daily living? Are they interfering with my job? So those questions, if the answer is yes, they're completely debilitating, then you really need treatment, right? But if it's a small cough and none of the other tests have really gotten to show anything serious, then maybe we just try inhaled steroids instead of putting you on some pills. So there's some things that we can do, and we really do have to have a conversation with you about, hey, treatment's tough. It's not necessarily easy. And so are you sure you want to do this? Let's see if there's something else that we can do first. We will treat, however, if we find sarcoid in the heart, the brain, or the eye, even without symptoms. Okay, so that is something that is important to keep in mind. And like I said, treatment is full of pros and cons. And so we really want to sit there and think about this. So there is a whole webinar by Dr. Raj who talks about all the different therapeutic options, but I just want to kind of touch on them briefly for you here, which is most of the time, 99.9% of the time, treatment is going to start with prednisone, and usually it's about 20 milligrams a day. It can vary up to maybe 40 milligrams, but usually 20 milligrams should suffice. And you want to treat for at least 6 months. And people don't understand this. They're like, oh, but I feel so much better after 2 months. Why do I have to continue it? Or there's unfortunately some doctors that will say, oh, well, you're better, let's stop it, because they don't necessarily know. So that you can be your best advocate by actually really understanding that if we get past 6 months, then we have a higher likelihood of putting you into remission, which is what we want, where it goes to sleep or it goes away completely. And if you don't respond or you start to have complications from our prednisone initially, then that's when we either add or switch to a different medication. And I've listed all of those here because there are quite a number of them. But there is not a single medication on this list, including prednisone, that does not come with a whole lot of side effects or complications that we really need to be thoughtful about. Now, there are plenty of patients who have no choice and have to be on treatment, and they can do just fine. They just have to, it's just another added layer of complexity to their life. Let's see if okay. And I guess the next thing I want to say is, like, what can you do for yourself? So really what we want to encourage you to do is really know your symptoms, understand what your symptoms are and are they related to sarcoid, track your symptoms, and track major events in your life that might have an impact on your symptoms. So we know that stress can activate sarcoidosis and many other health issues as well. So you want to keep track of stressful events or major things that are happening. You want to keep track of your own medical record, right? You want to have your past medical history, your surgeries, your medications. You want to know about medication allergies. Keep it all organized in one place for you in case you do end up having to see multiple different doctors. It will save you and them time. And then the other thing is it's really important to keep track of medications for sarcoid that you have tried, what doses you have been on, and what worked and what didn't work, and then also what side effects you may have had. So those are really, really key. You want to keep a folder of all your testing, right? So if you had a CT scan and breathing tests and blood work and stuff, you want to keep it all organized in one place because you're going to need to be able to have your doctor look at the sequence of events, but it also will help you, again, in case you need to see a specialist for something, and you'll have all that there. I can't emphasize enough that eating healthy and being active is important practically no matter what. So I will always say that. And then really the last thing is be your own advocate. We're here to help you at Life and Breath. And obviously your doctors who are passionate about sarcoid are going to help you, but you really do need to be prepared to advocate for yourself. So in summary, I hope I haven't taken too long with this. Every body is different. And so therefore, everybody responds differently. And I think that's a really important message, is that you are not a statistic. So whatever the statistics may be, you're not that person. So you are just one person. Once sarcoid's diagnosed, you really want to know about which organs are involved. So that's going to mean more testing. And hopefully you understood all the ones that we went through. And then just to remind you, most patients do not need treatment. But treatment usually begins with prednisone, and we'll go for 6 months. And the decision to treat's a big one because of those side effects. And we really do aim for remission. That is our goal. And if well managed, sarcoid can be a chronic disease that you live with. So these are some of the resources that I wanted to highlight to you. Life and Breath, actually, on the website, you can actually go and you can access these things. I can't really link on them straight from here, unfortunately, in my presentation, but they are a great resources for you to do all the tracking that I just mentioned. And then obviously Dr. Raj's webinar on different medications. So with that, I want to leave you with this pearl, and I am happy to answer any questions. Thank you.
Thank you, Dr. Carr. Thank you very much. We have quite a few questions. I'm going to start with the very first. When is a PET scan ever recommended?
So let me see, I'm trying to make this bigger so I can actually see you. Hi. So when is a PET scan recommended? Well, we recommend PET scans when somebody has cardiac involvement. So if we think the heart's involved, for places to be able to do that, for example, even in Baltimore, there really are not that many places that can do a cardiac PET scan specifically. So it's not accessible everywhere. Even if you're in a place where they may be able to do PET scans, they may not really be able to do a cardiac PET. The other thing is that if your insurance will pay for it, and so if I have a patient who I think may be relapsing, meaning that their disease they're having a flare, and I'm not 100% certain, and it's different than it was before, and maybe their lungs are not involved this time, and they were before, maybe I want to get a PET scan at that point to see if there's something else that I could maybe biopsy or go after. I want to see if there's activity. So PET scan is for active disease, if your insurance will pay for it.
Great, thank you. How long, when first diagnosed, do I start taking prednisone?
So prednisone is in experienced sarcoidosis world, prednisone is at least 6 months. So we may start at 20 milligrams. And at 2 months, you're starting to feel much better. That's great. We'll maybe start to come down very slowly. We drop it down by really, really small numbers, like 2.5 milligrams a month. So you'll be on 20 milligrams for 2 months, and then all of a sudden we'll be, oh, we're making progress. We'll drop you to 17.5 milligrams for a month, and then 15 milligrams the next month. It's interesting because one of the things that we found is there can be a sweet spot where the prednisone works. We want to get you to the lowest dose possible to keep your symptoms controlled. So it could be that 12.5 is your sweet spot. And sometimes if we go too fast, we miss it. So we want to take it nice and slow, but you want to be treated for at least 6 months. Some people actually recommend 12 months, even with symptom control.
Great, thank you. Next question. My pulmonologist is still searching for the right medications for me. I'm hypercalcemic. What tests should I be getting?
Well, when people have high calcium, there's a couple of tests that we get. One is calcium and vitamin D are linked together. So we check for vitamin D levels, but there's a very particular subgroup of vitamin D, vitamin D 1,25 hydroxylase, whatever, it's long. But that is a special vitamin D level that if it's high is suggestive that actually those granulomas are producing calcium, because that's one of the things that they'll do. So we want to look for that. We want to make sure that in those patients that they're not taking vitamin D supplementation, because actually a lot of people, so especially African Americans, may have low vitamin D levels, and they then, their primary care physician smartly says, oh, you need vitamin D. And so they then put them on vitamin D, but it turns out with their sarcoid that actually can increase calcium. So when somebody's has high calcium, we look at the vitamin D. We certainly decrease supplementation, right? So you wouldn't have your milk with extra calcium in it, right? You're not going to drink orange juice with calcium fortified in it. And then the other things that we look for is actually the parathyroid hormone. Parathyroid is the little tiny hormone that sits right next to your thyroid gland. And the parathyroid actually is responsible for calcium distribution stuff too. So you would get that tested as well to see if you actually have that as a primary cause for your calcium. But otherwise, really, it's just a question of treating the sarcoid, right? So prednisone is, again, the favored for calcium for people who have high calcium.
Thank you again. What test do you recommend for the liver checking for cirrhosis?
Well, cirrhosis is an advanced end stage process of scarring in the liver that is from multiple different things. So when sarcoid gets into the liver, we don't necessarily see cirrhosis in the beginning for sure. Like this would be really advanced disease. People who have cirrhosis really need to see a gastroenterologist because they need a liver biopsy. We actually have some really sophisticated, cool testing that we can do in the blood now to actually get a better sense of how much scarring there is in the liver. But there's also other things that can cause cirrhosis. So if you're looking at cirrhosis, if you show up with cirrhosis, sarcoid might be one of the things on that differential, meaning one of the possible lists of causes, but it's not the first, usually it's not the first thing that we see. I hope that answered the question. I know it's probably a little bit outside of sarcoid talk.
Thank you. When test results from other issues say unknown granuloma, should we assume it's sarcoidosis?
So I'm not sure exactly what that means, unknown granuloma. I've not ever seen that on a pathology report. Usually it's caseating or non-caseating granulomas. And then really the answer is no, I would say. I would not put all my eggs into one basket if you're getting something that vague. We really, really, really recommend that biopsy, and this is what I talked about in my other talk, but biopsy really should be in the lung. And so there's lymph nodes that get swollen and those can be biopsied, or the lung tissue itself can be biopsied, or both can be biopsied. The lung tissue, even if you don't have an abnormal CAT scan, so your CAT scan looks okay, we actually still find granulomas in the lung tissue. And so that's one of the reasons why we really use the lung as the primary place to get the biopsy. So, and I've definitely seen patients where they have an iffy diagnosis of sarcoid. And I mean, I had a patient, for example, who for 25 years, she thought she had sarcoid. She was being treated and she had went through all these different medications and nothing seemed to be working. And it turns out that she had an allergy to one of her medications that she had been on for life. And so when we took her off of that medication, everything disappeared. She had biopsies and they showed some granulomas, but they were not your classic granulomas. And so it was just it was a very, just a even granuloma does not necessarily mean sarcoid.
Thank you. Dr. Carr, how do I truly know if I'm in remission?
If you're feeling good, you're in remission. That's how we know. Because again, I just want to point out that treatment is really symptom driven. And so even if you still have sarcoid in the body, as long as it's not active and causing problems, we leave it alone, right? It's leaving you alone, you should leave it alone. So that's it. If you feel good, that's usually how we know. Again, for the ones where we are treating without symptoms, the heart, the brain, and the lungs, the heart, the brain, and the eyes, those ones are actually followed by imaging, right? So if you have neurosarcoid, most of the time patients have symptoms, but you can still have neurosarcoid, but we would use brain MRIs for that kind of thing. For the heart, we would use the MRI of the MRI of the heart, not necessarily the PET scan in that scenario. So the ophthalmologist looks to make sure that the eye is well controlled. So those are the things we do for those in remission for those particular organs.
Thank you. Next question, what is the objective criteria for deciding on oxygen use?
Oh, so Medicare has defined actually very strictly when they will pay for oxygen. And by definition, that means when we will actually end up providing it, right? So we say if somebody's oxygen levels on the pulse ox, which is the little finger thing that they do, if your pulse ox at rest is below 89%, so 88% or lower, then you need oxygen supplementation. If you're 95% at rest, but we take you on a walk up and down the hall and you drop your oxygen levels to below 89%, so 88% and lower, then you qualify for supplemental oxygen with activity. Most of the time, patients who need oxygen during the daytime with activity are definitely going to need it at night. And so that is really the main qualification. We have a couple of other things. It is not based on breathing test results, even if they are really shows very significant advanced disease. It really is based on just whether or not your oxygen levels drop when you walk or you start off at low oxygen levels.
Very great. What is the difference between a gallium scan and PET scan, and do they yield similar results?
So interesting, gallium scan before the advent of PET scans was something that we used to do because it was actually a way for us to look for sarcoid, and it's pretty good. It's pretty good. It's in the year 2022 for me in Baltimore, not a study that I need to do often. In fact, I haven't ordered one probably in about 15 years. But I've been lucky. I've been in a place where we have, access to great resources. So if that's all you have access to, that's fine. It will help you identify some areas that look like they have sarcoid. Great. And I didn't fully talk about what a PET scan is, but a PET scan basically is where we give you labeled sugar, and it's not really sugar, and it's a medical sugar, and we give it to you intravenously. And what happens is that if you have areas of activity in your body, they will take up the sugar faster. And so we have the ability to look at your body and say, oh, that area looks like it's active. And because it's called a PET/CT, it's superimposed with your CAT scan. And we say, oh, look at that. There's an abnormality on the CAT scan exactly in the same spot. Now that tells us something. And that's what we call active, right? Or some people might say hot, or some people, what else did they say? Yeah, I think stuff like that. So that's how the PET scan works. And it's really amazing technology.
Thank you. Physicians don't like to do tests to check for extra involvement. How should patients approach this?
Well, this is where you should advocate, you need to advocate for yourself. So if your physician, the physician who is telling you that they don't want to get more testing, happens to be a specialist in sarcoid, then maybe they're correct. Maybe they're saying that, You don't really need more. I will tell you that I get the standard basics that I listed, which is the CAT scan of the chest, the breathing tests, blood work, urine, and the EKG in the eye doctor. And those are the standard 6, like no questions asked, you're getting those. Now, if a patient says, well, I want a test for something else, and nothing in my workup so far has revealed an abnormality, then maybe it's not worth it for that patient to get that testing, right? Because that testing could potentially cause more harm, right? Every time we get a CAT scan or a chest x-ray, we're giving the patient radiation. While it's not a huge amount of radiation, I wouldn't want radiation unless I really needed it, right? So it's a way of sometimes doctors don't want to get testing because they don't think it's necessary, as opposed to, and sometimes that's hard to hear. What do you mean it's not necessary? Of course I want this because I feel like I need it or something. So if it's not one of those top 6, then you really should have a conversation with your doctor. And again, if you're having specific symptoms that are related to that, that's really what you want to focus on with your doctor then, is sort of say, look, I'm really having this pain in my calf. It's very particular, something like that. And that might be the way to have that conversation with them. We want doctors to be to really be your advocate, right? Like that's what doctors are supposed to do. And so I'd say 99% of the time, the doctor really actually does have your best interest at heart and really is actually trying to practice very good, safe medicine for you. But sometimes you might find that you're just not in a good relationship with your physician, and it might be time to find somebody else.
Thank you, Dr. Carr. Next question, are there any special tests beside follow-up brain MRIs for neurosarcoidosis?
Well, our nervous system is actually as amazing as the solar system or the night sky, right? There's a lot of nuances to it. So there is sarcoid that gets into the brain, but there's also sarcoid that can get into the nerves throughout the body. And so generally speaking, if your primary diagnosis for neurosarcoid was a brain MRI and you had evidence of sarcoid on that brain MRI is going to be the tool that you're going to want to use to follow that. If you have sarcoid in other places outside of the central nervous system, then it might be a different way to follow it. But usually, whatever the original diagnosis or how the original diagnosis was made is a very important way to follow your disease progress. For those who are not symptom driven, where it's really more the 3 major hidden ones.
Thank you. Next question, I've never had a head to toe exam. I was diagnosed over 12 years ago. Is it really necessary at this point?
No, I mean, I'm sure you have had a full exam head to toe, you just maybe didn't realize it happened because, it's a doctor who's been doing this for some time can really get a lot of those systems, organs done quickly, right? And you might not even realize it. But no, at this point, if you've been living with your sarcoid for 12 years, then you probably know your disease better than anybody else. And you don't need to go looking for things that are hidden, because if they were hidden, they would have declared themselves by now, right? And sarcoid it's not the problem with calling it staging is that it doesn't necessarily progress from number 1 to number 2 to number 3 to number 4 without treatment. That's not at all what happens, which is why I don't like that name so much. So it doesn't necessarily mean that you are not aware that you have sarcoid somewhere else.
Great, thank you. If you have hypercalcemia and are also menopausal and on steroids, how do you avoid osteoporosis? What tests should you take?
Well, osteoporosis is really tough for patients who have to be on steroids. And so for patients of mine who get osteoporosis, which is diagnosed on a DEXA scan, If they get osteoporosis, then I will work very hard to get them off of the prednisone, right? I then switch them to something else, because one of the main side effects of prednisone is to cause osteoporosis, right? It actually can degrade the bone. And that is a consequence that we do not want. And women who are perimenopausal, postmenopausal are at very high risk for osteoporosis. And so, yeah, you know, and plus you can't take calcium supplements, right? Everybody says, oh, take calcium if you've got bone issues, and you can't do that if you've got high calcium levels. So that is definitely where you want to get off the prednisone and onto one of the other therapies that we were talking about.
Okay, thank you. Next question, I'd like to know the answer myself. What's burnout sarcoidosis?
Oh, well, that's burnt out sarcoid is that category I was saying, where you have evidence that there was a war in your body, right? You have these fortresses that were built, but the army's gone and the party's gone home, and you know, you're just left with the structures. There's no active disease whatsoever anymore. And, you know, I've seen that a fair amount, especially with patients who have stage 4, which is the fibrosis part. I've seen fibrosis just burn out, and they still have fibrosis, that's scarring, on the CAT scan. They still have evidence of lung damage on their breathing tests, but they're able to function fully in life without any treatment. So that's burnt out sarcoid.
Great, thank you. How often should I get a CT scan for pulmonary sarcoidosis?
So I, for my patients that I'm following, either they're on treatment. Well, first of all, if my patients are on treatment, I see them fairly frequently. Patients who usually in the beginning, we either see each other every 6 weeks or 3 months, kind of depending. And then once they get into a steady, stable state, I might see them every 6 months. I will get a CAT scan every year, once a year. For patients who go into remission, so their disease has gone to sleep, they don't need any treatment, I still get a CAT scan every year. And again, every year, once a year, I get the CAT scan of the lungs, the breathing test, the eye doctor, the EKG, blood work. Uh-oh, I forgot my sixth. oh no, and the urine, maybe, I can't remember. So anyway, I get those every year, no matter what. So there does come a point where I might stop actually checking those, maybe after 5 years of you being completely symptom free, no evidence of anything secret hiding anywhere on all the workup, then we might slow it down, because again, if you don't need to have the radiation from a CAT scan, why have it? So but that's an individual person. Each person is a little different. Everybody is different. So that I can't say 100%, but I sort of at some point I start saying, well, I don't really know why we're getting this. Just come back to me if you start having complaints, or some issues again.
Great, thank you. Is the treatment for sarcoidosis different if it's found in different organs like the brain, liver, or lungs? Are there different meds for these different organs and diagnoses?
So again, 99% of the time, we start with prednisone. Prednisone is very effective against sarcoid. So there are definitely times where a patient becomes either intolerant to prednisone, the woman who develops osteoporosis, for example, or who has diabetes that's getting out of control or something like that. Then we want to put them on alternative medications. And there's a few medications that are a little better for this or a little better for that. But really, it's sort of, we have tier 1, first time around, is prednisone. Then if prednisone doesn't work, we go to what I call tier 2. And tier 2 is the methotrexate, leflunomide. Those are very commonly used. Other ones might be Celcept or mycophenolate mofetil. That's the same thing. Or azathioprine, also known as Imuran. So that's the second tier. And if that doesn't work, or we need more, then we go to the third tier, which I call third tier, and that is the injectables, where that's infliximab or Remicade and Humira is the other one that we use a fair amount. And that's the third line, meaning, you know, you've not gotten resolution with tier 1, tier 2, and now we're on tier 3. Most of the time, if, you know, especially with neurosarcoid, we take it very seriously because, you know, obviously the brain is, not that we take anything less seriously, but neurosarcoid can really have a significant impact on person's lifestyle very quickly. So that is actually a probably more aggressively treated area. And if prednisone doesn't work in a short order, we probably would move on to the next stage pretty quickly.
Great, thank you. Next question: when is someone considered in remission? If I don't have symptoms anymore, how often should I get checked or see my physician?
So, great question. I'm going to say it really sort of depends on how close to your new remission is, right? So remission, again, is where your symptoms are gone. Because again, other than the three sort of rare things that I talked about, we're going to get back to like the more common stuff: skin, lungs. So, you know, somebody who has a cough, somebody who has shortness of breath, somebody who has some chest tightness, not chest pain, heart, but chest tightness. Somebody who has a skin rash, disfiguring skin rash, you know, things like that. We follow the skin rash goes away. Now we start to take you off of treatment, and, you know, we're able to get you off of the prednisone altogether. The rash doesn't come back, you're in remission. And so you're in remission, you can look in the mirror and see that rash, right? And so you can tell when it's coming back. So you don't necessarily have to have your doctor see you for that, right? But if you had lung sarcoid or lung sarcoid, and you were being treated for that, you might want to be checked, you know, only if you had symptoms again, but at least once a year. And at least once a year again with the CT scan, the breathing tests, maybe I'll get it right this time, the EKG, the blood work, and the eye doctor, and the urine is the number 6. So if you know, those you should do every year. And again, for me in my practice, I like to do that for, on average, 5 years. Now, there are some patients where maybe after 2, I might let them not continue on with their scans and imaging and stuff, and just come back to see me if they have a symptom, because they had a skin rash to begin with, and that's their like window to sarcoid, right? So if they have a problem, they're going to call me immediately, right? As opposed to some of the other situations where we might not pick it up early enough.
Great. Next question: if you flare within your first 6 months, say they are weaning you off and you get sick, does that mean you will be chronic, or can you go into remission? I was at 12.5 milligrams. Then they shot me back up to 30 milligrams because I became sick and symptoms flared.
So there's lots of things that can make you flare. You might be on a really good trajectory. Things are, you know, going along, and you get COVID, for example, right? And all of a sudden your sarcoid flares. That should not put you into a tailspin that, you know, life is miserable, terrible, whatever, and I'm going to die of sarcoid. So it might be that you sort of, you have to reset the clock, and you're back up to 30, and now you got to work your way down again. I have had plenty of patients who are on a tapering dose. I've had plenty of patients who get down to 5 milligrams, say, and they spend time on 5 milligrams, months, and then they get COVID, and they now need 30 milligrams of prednisone. But you know, again, for me, usually 20 works, but sometimes even 40, like with asthma or COPD exacerbation, we use 40. So we might do 40 for 5 days, and then get you right back down to 20, and then, you know, start to go down again from 20. So it's not, first of all, we don't have enough data to say, oh, this is exactly how you're going to go. And I will remind everybody that statistics really are just a number, and you are not a statistic. So you should really not assume that you're going to have chronic disease just because you had a flare in your first 6 months.
Great. Next question: I've heard other patients say they see a rheumatologist Do you recommend this or think it is necessary?
So, so interestingly, actually, when I was out in Salt Lake City, which you mentioned in my bio, at the University of Utah, the rheumatology department actually is very strong in sarcoid until I got there. So they didn't really have any other team members to work with. So I work very closely with rheumatology. Rheumatology is great when people have a lot of joint issues. And the reason they're good for joint issues is because they can help really crystallize whether it's sarcoid or something else causing the arthritis. Because again, I'd hate to treat somebody as sarcoid if they actually have osteoarthritis and they just need Tylenol, and that's not really my call to make, and I'm not an expert in that. The other thing that rheumatologists do very well is they handle a lot of the autoimmune diseases that we actually will use the same medications for. So they do rheumatoid arthritis. That is their big specialty, and a lot of our data on therapies for sarcoid actually come from the literature for rheumatoid arthritis. So there's a lot of overlap. And so I think a rheumatologist, if you've got a rheumatologist that is comfortable and happy dealing with sarcoid, great. It is not necessary, but if you do have a lot of unusual joint things or something like that, it might be worth at least seeing a rheumatologist at least once.
Thanks. Next question. Dr. Carr, you mentioned a patient that had a medication allergy that caused granulomas. Can food allergies cause granulomas that look like sarcoid? Or how can I know if I have a sarcoid or if it's something else?
So I'm going to tell you that is a great question. Best one of the night. So we have to go back to the grain of sand for the human. We actually do not know in the year 2022 what that grain of sand is, right? We know that a grain of sand causes irritation in an oyster shell. It produces a cocoon. We do not know what triggers the human. So could it be a food allergy? Yeah, it could. And your body, if you have an allergy, it's like your body's trying to protect itself against something. And your immune system is being overactive. And, people who are allergic to pollen, right? They get a runny nose, they get all these symptoms and stuff, right? And that makes inflammation, it just makes people feel terrible. But, that's part of our body's response to something, right? And so that's what's happening. And so it could be an allergy. It could, we could find out in 20 years from now that all the sarcoid's been an allergy to something, but we just don't know what it is. That's the problem. So for my patient who had a drug allergy, I mean, that was the first time in my 20 years that I ever saw something like that. It was amazing. I mean, but that's not the common thing. With food, however, we know that there is more sarcoid in America and the United States than there is maybe in some of the countries in Europe, right? The diet here is very different than the diets over there. Am I going to tell you that, I know specifically? No. I do have another patient, of course. I have another patient who actually has had some really unusual presentation of her sarcoid, and she is a huge advocate for herself. And I'll tell you, I think I've mentioned her before on the show. I mean, she's just one of my favorite patients, but she found that gluten actually was the cause of all of her symptoms. Everything that we were actually treating with sarcoid. She has biopsy proven sarcoid. We know she has sarcoid, and she removed gluten from her diet, and she has been able to come off of all of her medications, and she has no more symptoms. So is that true for everybody? Maybe, but how are you going to go about figuring that out? So one of the things that they talk about is actually an elimination diet. So there's two ways to do it. You either you stop everything normal and you start eating the most bland baby food diet. And then you reintroduce things like 1 week at a time. Or you can go the other way and just remove things from your diet 1 week at a time. The tricky thing is my husband has, and it's probably more information than everybody needs to know, but my husband has food allergies. And so I spend my time looking at all the labels of all the things at the grocery store. And I can't believe the stuff that's hidden in there. Like, oh, well, no wonder my husband can't tolerate that, because, you know, they've hidden it in there. So I think that part's hard. If you are going to do the elimination, you know, like getting rid of something once a week, like, you know, get rid of gluten, you've got to go all in. You've got to absolutely 100% be totally committed. You can't let gluten sneak in anywhere, right? And so that's difficult for some people. But if you can do it, absolutely, more power to you. And why not? What's the harm, right? You're not going to have any harm in doing that. You're not taking medications. This is a very healthy approach to things if you can do it.
Dr. Carr, thank you very much. Unfortunately, we can't give credit to that person because they're anonymous attendee tonight. But thank you very much for that great question. It was #1 in Dr. Carr's list. So, Dr. Carr, thank you again very much for answering the questions. For those few questions that we didn't get to, we'll see what we can do. If there's some we can answer on our website, we'll do our best. But again, thank you everyone for attending tonight. Obviously, we have a lot of questions, a lot of interest in this topic, so we do appreciate your participating online. And we do have webinars every month, so please look at our website to find out the next webinar. And again, thank you, Dr. Carr, and all the attendees. Have a great night, and thank you for attending.
Oh, it's my pleasure. Thanks so much for having me, Sal.